Rabbi Dennis Sasso of Congregation Beth-El. I'd like to welcome you all to this evening's Zoom virtual Cocktail Judaism program. Just about a month ago, on March 24th, we had Dr. Aaron Carroll converse with us on medical aspects of the COVID-19 pandemic. And then a week after that, in early April, Ron Klain engaged us in a conversation on national and international policy issues surrounding the pandemic. And tonight we continue the conversation with two distinguished medical professionals of our own community, an epidemiologist and an ER physician who are in the front lines of the struggle against the COVID-19 pandemic and challenge that is before us. I'm going to introduce them both and then begin a conversation with them. Dr. Amy Kressel is an associate professor of clinical medicine in the Division of Infectious Diseases at the Indiana University School of Medicine. And she serves as medical director for infection prevention and antimicrobial stewardship at Eskenazi Health. She currently serves as an appointed member of the Society for Healthcare Epidemiology of America, of the CDC, Outbreaks Response Training Program Advisory Panel. She serves on the Indiana State Department of Health Antibiotic Resistance Advisory Committee and the Indianapolis Coalition for Patient Safety of the Multi-Drug Resistant Organization Work Group and Influenza Work Group, and a bunch of other stuff. Dr. Kressel's work combines infectious diseases expertise with hospital leadership and systemic change. She leads programs that protect patients by reducing their risk of harm when hospitalized. And as you will see in a few moments, she has a very contagious personality. Dr. Kressel, her husband, Rabbi Bruce Pfeffer, and their children, Leah and Max, are members of our congregation. Rabbi Pfeffer is a dear colleague and a rabbinic hospital chaplain in our community. And Dr. Jamie Harper earned her BA in Hebrew and Jewish Cultural Studies from the University of Michigan and her MD from Wayne State University School of Medicine. We're going to conduct part of the conversation in Hebrew, if that's okay with you, Jamie, as we move along. She did her internship in general surgery at Rush University in Chicago and her residency in emergency medicine at Cook County Hospital in Chicago. Dr. Harper has extensive experience in emergency room work at Rush University Medical Center as the director of the ER at Henry County Hospital as an emergency room physician in St. Vincent's. She currently spends most of her time working at St. Vincent's on 86th Street and St. Vincent's Carmel. Jamie and her husband, Dr. Stanley Harper, and their children, Jackson, Sarah, and Aaron, are members of Congregation Beth-El. So we are delighted to be among family and distinguished professionals and colleagues, and with so many of you who have joined us for the conversation tonight. So I'm going to begin by asking Dr. Kressel a kind of general question, and then we will try to break it down into more specifics. But Dr. Kressel, what does the future hold for COVID-19 and for us? Of course, as Amos would say, we are not a prophet nor the son of a prophet, or in your case, the daughter of a prophet. But none the case, that has never stopped Jews from prophesying. So tell us a little bit about the landscape.
Okay, and you can all still hear me?
Yes, perfectly.
Okay, so I'm so glad you said I'm not a prophet. There are key pieces of information we don't know. We don't know the true number of people infected. And we don't know true death rates as a result. So clearly, what's going on is worse than influenza. Already more people have died in Indianapolis this flu season from COVID-19 than have died from influenza. But we don't know if that's because the virus is inherently more dangerous or if it's because it's infected many more people than influenza has. So in a normal influenza season, about 8% of the population gets infected. This is a brand new virus that human beings have not seen before. We have no vaccine and no pre-existing immunity. So it stands to reason that a lot more people could get infected than the usual 8% from influenza. But because we're learning that a lot of people have no symptoms at all when they get sick, and because we don't have enough testing kits, we truly don't know the numbers. There is some like interesting peeks through the window. So in Santa Clara County in California, they tried testing a swath of the population, and they found that probably the official numbers of infections based on doing the PCR and nasal swabs captured 1 out of 50 people. So it's not unreasonable to think that our official numbers are off by 50-fold. And it could be more, even more or less than that. But that's just we're just getting tiny peeks about what's really going on. I think that this is not going to go away. When the news first started coming out of China in December and January, I was hoping it would be like SARS-1, and I was really hoping that we could contain it. Nobody has seen SARS-1 for the past since 2003. It was really eliminated from human beings, but I think at this point that's not going to happen. So just like the 1918 influenza epidemic heralded influenza recurring year after year in human beings, I think this is going to be annual. But I think I don't think we know yet if this will be seasonal. I think we could likely have multiple waves if we think about influenza and look at what happened in 1918. It's possible we'll get a reprieve in the summer, but with so many people who have never seen this virus before, I don't know how much of a break we will get this summer. It might eventually settle into another winter and fall illness, but I think all that is unknown. I'm hoping that we will develop a vaccine and antivirals. And I think those things are going to be important in the next few years to try to get a handle on this. But I think we're going to see repeated waves of infection, probably having to have some form of social distancing or physical distancing intermittently for a while. I'm hoping that we'll get better testing, more testing to see who's sick. But I think another thing would be serological testing. What we really need is accurate antibody tests that will actually tell us who's immune. And not all antibody tests would tell us that. So I think we're all still waiting if we have a true immunity test. So much for my being a prophet.
Well, you've covered a tremendous amount of ground there. Can you, without being a prophet, can you see a timeline for a treatment and a possible vaccine?
Well, I think we need more information from the remdesivir trial. That's a drug from Gilead that's being tested. The data I've seen doesn't tell me a lot about how great it is. I think the data that came out was from a compassionate use study. The thing is, most people will get better without treatment. Most people are either not having symptoms, have moderate illness, and are staying home and never go to a hospital. The majority of people will leave a hospital alive, even if they get admitted. And what we're starting to see in our community and elsewhere is that if we give people supportive care and put them on ventilators, most people, I shouldn't say most, many will actually survive and be able to come off the breathing machines. But once you're at that point, you're on the breathing machine a long time. So I think those are good things. it also makes it hard to know if an antiviral is working. I guess I should make a public service announcement. There's been a lot of hype about hydroxychloroquine, but now there's more information coming out that it may be causing more harm than good. So a lot of us are not as enthusiastic about it now.
That was already anticipated.
There was concerns because the data supporting it were weak to start with.
Right.
I just wanted to throw it out there because there's been a lot of hype about that. Now, as far as vaccines, there are dozens of candidates being looked at. But I think we should remember the Ebola vaccine took about 5 years. People don't realize this because COVID has knocked everything out of the news, but there is an Ebola vaccine, but it took 5 years. So I think when people are talking about 18 months, that is really, really optimistic. I personally think it's going to take longer. And there are situations where where an immune response can actually be worse. So a lot of people running into trouble with COVID, it's because your own immune response is actually overactive and overreacting. And one of the really important things for a vaccine is to make sure that the vaccine does not do that. So having a vaccine is one thing, but having a vaccine that is both safe and effective is quite a different thing. So I honestly think 18 months is way too optimistic. I'd be happy in 2 or 3 years.
Wow. I want to come back to the issue of the flattening of the curve, as they say. But let me go to Dr. Harper, to Jamie, and ask her, you have given us kind of the more global, national and state picture. Jamie, what are we seeing on the north side of Indy in regards to the coronavirus? And how is it different than what is being portrayed in the news and what Dr. Kressel might be describing at a more global level?
Sure. I definitely am not an academic. I'm not an epidemiologist. I'm just your ER doctor. So I split my time between St. Vincent's 86th Street, where I was last night, and St. Vincent's Carmel, where I was about 4 or 5 days ago. So our situation is a little bit different in Indiana than what you're seeing on the news. I will tell you that we have the resources. I have exact numbers from Ascension Health, St. Vincent's side. I will tell you that we're running at about 50% capacity on our ICUs and about 30% capacity on our floor beds. So we have plenty of space for patients. We've got plenty of equipment. We have, right now we're looking at it, we have a 30-day supply of personal protective gear for all of our employees. We are not reusing things. Our situation is not as dire as it is in New York. As far as testing in Indiana right now, and I know there's some IU doctors on this call. At St. Vincent's, we use Mid-America Clinical Labs for our testing. They have the ability to run 65 tests of the rapid test daily. So that's a test that's turning around results in about 45 minutes. I will tell you, in reality, they're batching them. They're sending them all downtown. So we're getting around 6-hour turnaround for a COVID test on our admitted patients. Our discharge patients are currently going through the state lab. So we are sending through Lilly is where it goes. We're sending their stuff out. So it's about a 24-hour turnaround to get results on patients that are going home. So in the inpatient world and in the ER world, we're still getting testing. We're still getting results. We still have supplies. I just want to veer off for COVID for 1 second. One of the biggest concerns that we're seeing, at least on the north side, and I'm assuming downtown is the same thing, is everybody wants to avoid the emergency room. Totally get it. No one wants to be where there's COVID. We do have all precautions in place to isolate our COVID patients from our non-COVID patients. We've seen this huge uptick in people with strokes and other diseases who are not presenting to the ER. So they're having stroke-like symptoms. And in order to treat a stroke, we need to give you clot-busting medication within 3 hours. And people are waiting, so they're coming in 24 hours, 36 hours after their onset of symptoms, which is too late to treat. So I just want to let you know, in Indianapolis, our hospitals are not overcrowded. We have the equipment. We can isolate you. So if you are having a non-COVID medical problem, I still suggest that you are seeking medical care. I know we're seeing 2 to 3 times the amount of people dying at home than we normally would see in an average day. So I just want to let everybody know, like, we're okay here in Indiana. We're not New York City. We have the resources. We can test COVID patients, non-COVID patients. So if you're truly having chest pain, stroke-like symptoms and stuff like that, I still think it's important that you seek emergency care here in Indiana. we're in an okay place right now.
Jamie, could you continue in that thread and tell us a little bit about telehealth and ways that patients can still contact their doctors for non-COVID-19 related symptoms and issues during the pandemic?
Sure, that's a great question. If you're having something that you're not feeling well, whether it's just like cough, runny nose, or UTI symptoms, or something that you don't think is emergent, I would still recommend that you call your doctor's office first. IU Health, St. Vincent's, they all have telehealth platforms available to all their physicians. So there's a pretty good chance that you can still see your own doctor via telehealth. If you call your doctor's office and they are not seeing you via telehealth, both hospital systems, and I don't want to leave out Community and Riverview, I think everybody has it, where you can log into their telehealth platforms. From those platforms, you are going to see a local Indiana doctor, most likely Indiana. We've given our ability for other doctors throughout the state to treat Indianapolis patients and Indiana patients, but you're going to see a real doctor here in the United States who can diagnose you, treat you, write you prescriptions if you need it. So there's no need in this pandemic to feel like there's no medical care for you. I know we're delaying some non-emergent surgeries and we're delaying some testing and stuff, but still, if you have any medical concerns, I just want you to make sure you're reaching out to your doctors, because we're still here. We can still treat other conditions, and we're just really concerned that we're seeing everyone stay away from seeing medical care and getting the appropriate testing and things that they're needing. I've seen a lot of people with simple infections that could have been treated by talking to their doctor, not wanting to, quote, bother their doctor, which their doctor is fine, you can see them, and then coming in and having to go to my ICU because they waited too long and they got sicker. So I just want to urge everyone to make sure you're still getting the medical care that you need.
What you're saying is in striking contrast to what we hear about New York. Just was a New York Times headline a while ago: people with serious illnesses and struggling to get treatment in the pandemic. The healthcare system just cracked open and swallowed them up. So what you're describing for Indiana, it does not reflect that crisis.
No, so we are not in New York City. I will tell you, I've done some telehealth calls, and we're even backing up the New York City 911 phone calls through some of our platforms. But we are not New York City. We can handle our volume. We don't have the cases that New York has in our healthcare system. I mean, I'm not an employee of St. Vincent's. We're an independent group, and I will tell you that they have stepped up to the plate. And I feel like all our Indiana hospitals are in okay shape, and we're here for you still.
We come back to Amy now. Pick up on that thread, Amy. I think Indiana was said to be the 11th state in the country in a recent report in terms of its handling of the pandemic. Are we going to be seeing, or are we seeing already, a flattening of the curve in our state? And what can we anticipate? And will that hold?
Yeah, so I think the rate of increase is slowing. I think we're optimistic but cautious about saying we're seeing a plateau, because New York and Washington saw stuff like that and then it went up again. But we're hopeful. But you had mentioned flattening the curve earlier, and flattening the curve is why we're not in dire situation here in Indiana. As Dr. Harper was saying, we can still handle our patients. We're not having to do crisis standard of care. But if we don't keep doing what we're doing, if we were to allow things to start increasing too quickly, we would overwhelm our capacity. So, and that's where the situation gets dangerous. That's why in New York, they're having such problems, because the number of people needing advanced medical care exceeded the number of ICU beds. We haven't had that situation yet. I know there's a lot of debate about when it's safe to all go out again. I don't know yet.
So would you say that the measures being taken by our governor and the state of Indiana health officials are different in any way from those of other states in similar size and impact? And are they in concert with the pronouncements and directives from the White House, or are they?
Well, okay. I think Governor Holcomb has done a good job. He was pretty, I think the New York Times article said something like he wasn't the first to say we needed to socially distance, but he was in the first group to say it. I feel like in Ohio and Indiana, we've done what has to be done based on our cases. We canceled March Madness. You could argue maybe we could have canceled some other events sooner, but it was really hard to know because we didn't have known cases here. But I think that he has really tried to follow the facts. I think that it's really hard for our governors to know where that inflection point is. Where is the harm of distancing worse than the harm of letting go? Because it's hard for people who depend on programs like school lunch programs, right? It's hard for them. It's hard for people who don't have home internet to continue to go to school. So there is a price to be paid with the physical distancing. So I think that various groups have laid out certain guidance about when you would loosen up. One of which is to carefully see what's going on. There's been a lot of talk about when we could start doing some of these elective surgeries again and what we would need to have happen. We definitely need a steady decrease in cases to do that. But I was going to say something else, Rabbi Sasso, and I lost my train of thought.
Happens to me all the time.
But yeah, what you want is a manageable number of infections, because if you are sick enough to be on a ventilator, that ventilator could actually save your life. It's not like being on a ventilator means you're too far gone. It's quite the opposite. So we really need a situation where we can get everybody who needs to be on a ventilator on a ventilator.
So would either of you, venture a guess as to when the state of Indiana might begin to loosen up on the social distancing measures that we have? We have a lot of families who are scheduled for bar and bat mitzvahs and all types of life cycle celebrations. And we certainly, despite being a religious congregation, are not prophets, nor sons or daughters of prophets. But as we begin to look into the end of it, let's say as we begin to look into the high holy days and into the end of the year, what would you say we might anticipate without making any promises?
I don't have a great answer for that, to be honest. I mean, I know the disease. I see it. I've seen a lot of it. I don't know. I mean, I'm biased. I'm obviously the wife of a plastic surgeon, so I would like him to do some cases to get out of my house and keep busy. But, I don't know. Right now we're doing okay in Indiana. So I think whatever we do to open things up, it needs to be gradual. But I don't think any of us, at least on the front line, have any clue. I mean,
yeah, and you could do a staged reopening, Rabbi Sasso. So you would want to see cases clearly decreasing, and maybe do like open more businesses, but not do big social things, right? Probably no big sporting events or concerts. So see how that goes.
So we can't expect to have the usual 2,000-3,000 people who would show up at Shabbat morning services regularly in the months ahead, right? Let me ask you just one very down-to-earth basic question. Can either or both of you just offer some very common sense, helpful advice to people in our congregation and community who might have questions? Should I go to the supermarket? What can I do? What can I do in order to maintain a relatively normal and not isolated lifestyle?
You know what? We live in a very walkable neighborhood. I think as the weather gets nicer, people should really try to get out of the house. you don't want to be going out of the house in large groups, but you could certainly, you and your family could take walks and bike rides. I mean, I know the Monon Trail got closed because people were congregating, and you might not want to go to like a crowded park. But if you could be outside air is amazing because there's UV light and there's lots and lots of dilution in the air. I mean, it's really good for you, and I would do that. And as far as grocery shopping, I don't think it's a good idea to go every day. But I think if you go once a week, you're very targeted, and the stores are getting better and better about limiting the number of people in the store, about kind of marking out 6 feet so you can kind of keep your distance, bring hand sanitizer, wear your cloth mask, wash your hands, don't touch your eyes and face without using your hand sanitizer. I think those are reasonable things to do.
So did you say dilution or delusion?
No, dilution. Outside air, anything you
Okay.
cough out is going to be very quickly diluted by the very large amounts of outside air. So as long as you're 6 feet away from other people and wearing your cloth mask, if you're outside, if you're truly outside, I mean, indoor spaces are different.
Absolutely. Jamie, any other thoughts?
No, I would totally agree. Getting outside is fine. I know with our family of 5 and a dog, we've been going on walks every day. I've made everybody get outside because I do think even for just mentally, you just need to get outside and see some sunlight and stuff. I think that's great. As far as grocery shopping goes, I mean, do you really need to go? I mean, you can have it delivered. I think if you can use Shipt or you can use, Market District pickup or something, and that's an option for you, I think that's a better option than going to the grocery store. If you have to go to the grocery store, you got to do what you got to do. You need food and stuff. But I think looking into some of those delivery options is a great way to get your groceries delivered. And I know that the waits aren't too long. I know I see online people are waiting weeks and stuff. I logged on yesterday to Meijer and they're delivering tomorrow. So I do think that looking into some of those options is probably helpful, at least for the short term.
Yeah, we're beginning to see in the neighborhood, certainly ours, a few more people going outdoors as the weather becomes nicer. But most people seem to be very respectful of the distancing requirements, and people are eager to see one another, but at the same time, very cautious about moving forward. So I'd like to pause and entertain questions from the audience, from all of you who are participating. And you can either kind of make yourself known to Jackie, or you can go in the chat section. There seem to be a couple of questions there already. Here's a question. Is the goal of flattening the curve to get us as close to 100% hospital capacity as possible without exceeding it? Or is the goal to prevent the transmission of the virus completely? This is a question from Ali Fleischer.
I don't know that we can prevent transmission completely, but flattening the curve is to make sure it's not to completely match cases to capacity, but make sure we don't exceed capacity. Flattening the curve would over time reduce cases overall. That's what happened in 1918. So sorry, I'm looking at the chats. But yeah, it's basically to make sure that we don't overwhelm the system.
That question was actually from Paul Felix. There is Dr. I think it's Dr. Pristowski, who said that he could add some data to this discussion if you wish, and we do wish. Dr. P, where are you? Okay.
Say we can't hear him.
We can't.
Yeah, because you muted me.
There you go.
There he is.
Hi, first of all,
This is Dr. Eric Pristowski.
hi everyone. To both of the doctors, great discussion. Thank you. And thanks for all you're doing in our ER, Jamie. Appreciate it very much. A couple of quick things. I got involved because of this issue of hydrochloroquine and its effect to cause lethal heart rhythm problems. And people should calm down, first of all. Not that it's even useful, because most of the data would suggest it probably isn't. Again, not randomized trials, but there's a wealth of data now from New York and from Washington State, as well as New Orleans, that I've been talking to people. They're not seeing much, but it's going to rarely cause a lethal arrhythmia. It can, but we've put things in place as most people have. I also like to support with, I forget which one, whether it was Amy or Jamie. So Dennis, I'm sure you have some joke about that, but I'm not going there.
They're bound by the J.
Yeah, I knew there was something. I wasn't going to go there, but it's a very good point that I think maybe Jamie made. We're doing all these video calls now with patients, so I've been home because I'm an old guy and I've been asked to do things at home. And I had a patient this week who's been in heart failure. And fortunately, I was able to get him on live, and he just refused to go out. And we finally admitted him emergently to the heart center, and he's being taken care of. But he could have died because he was afraid to go out. So Jamie is 100% right. You have to take care of yourself. The question I asked, though, for either one of you, I've been doing a lot of reading about this cytokine storm, and not sure where I'm at in my own reading of it as far as what do I think about it. Amy or Jamie, either one of you have anything to add to that, and maybe you can elaborate on it. I think it's fascinating. And I know we've have drugs at St. Vincent. I'm sure most places do now that can fight it. But Amy, maybe you might want to educate us on that issue.
Right. So as I mentioned, what seems to be one of the causes of death is an overreaction of the immune system. So what you're calling a cytokine storm. There are trials going on of some drugs to stop that. I don't want to throw out names because there's just been too much frenzy about names. We've used, I think we're trying to get a trial going where I am, and there's another drug that we've been using in some of our patients. I don't want to promise it's helping them because we don't have enough data. But yes, that is a strategy, and that's a strategy that's being actively looked at.
One of the most interesting things about this whole thing is how we've changed some of our treatments. So working on the front lines about 2 weeks ago, we would have put a breathing tube in anybody who came in with a saturating about 75% oxygen. So their oxygen was really low, and we would have just automatically put a breathing tube in them. And as recent as yesterday now, we're changing that. We're using a lot more high flow oxygen. We're using that prone, like you guys have all seen on the news, where we're putting people on their stomachs and letting them breathe and having some good results. So I think a lot of it is just changing day by day and kind of looking at the data coming out of our country and out of the hot spots and how we can kind of change and alter some treatments as we go.
Thank you. I have a note here that Stuart Fox has a question. Stuart, you want to speak it?
Yes, please. I'm a high-risk individual, as well as many others in the congregation. And as the distancing situation opens up and people go back to work, it's going to become more problematic for those of us who are at high risk. And to what degree, or what guidelines can you give us so that we don't remain totally isolated and are able to conduct fairly normal lives, especially as time goes on and things do open up?
Either one of you?
I don't know that our lives are going to be able to go completely back to normal. I do think that for a while, until, like Amy said, we're getting vaccines out there and stuff, I think you are in reality going to have to wear masks in public and do social distancing and not, go into, packed concert halls and stadiums and stuff. Having said that, I think as time goes on, you will be able to see your loved ones and be in smaller groups and stuff, as long as you're being careful. And if someone's sick, if someone has a fever, they're staying home, they're staying away.
And I think if we get reliable tests of immunity, that would be really helpful, right? Because there might be some people who already had it and are immune. And you might already know somebody. I mean, again, we don't have the immunity tests yet, but I know an increasing number of people who've had it and they know because they had the nasal swab test and have recovered. So those people might be like a safe contact for you at some point in time. Just thinking about it that way.
Here's a question that follows up on that because it has to do with testing.
No, you can do it.
Hold on. Here we go. It's from Eileen Smith. It's a question regarding testing. How can we determine a rate of infection or herd immunity without effective testing? I have heard that testing has an approximate 33% false negative positive. Which testing company shows the most accurate results? Until we have a vaccine, do you think at some point that everyone will get it? Presume the testing.
No.
Right. So we.
Virus. Oh, get the virus. Yes.
Right. Not a prophet. I don't have comparisons of the different test methods. We ask our lab that all the time. Again, CDC announced today that they have some serological tests. I think they're not ready to roll that out prime time, but I think eventually doing antibody tests is going to be the way to know, because I suspect that for every person we know who's been infected through today, going back to January, there are probably many other people who had it who didn't realize it. I'm sure I'm not the only person on this Zoom who was sick in February and is wondering what I actually had. So I think the real answer to knowing who's immune and who had it is going to eventually be the antibody tests, but not today.
Any other questions?
No, there's.
So
Okay, I have a question.
here,
I have a
look, here's the situation. Jamie is a doctor married to a doctor. Amy is a doctor married to a rabbi. And Sandy is a rabbi married to,
a rabbi.
I don't know.
It's time to look.
We have all the three permutations here. So here's a question from the other rabbi to the doctors.
Well, I'm just looking at how hard it is to get tests to people now, that even when we get a vaccine, how successful will we be in getting it out to everyone who needs it? I mean, how equipped are we to make sure that everyone who needs a vaccine is going to be able to get it?
God, you guys are asking me to be a prophet here, and you keep telling me I'm not a prophet. I don't know. I mean, hopefully we would have more than one manufacturer and more than one effective vaccine. We actually, Rabbi Sasso, do a really good job every year getting flu vaccines to people who actually want them. I mean, not everybody gets it, but there is a really great distribution system to get it out to people. I think part of it depends on whether they're using new or old technology to make the vaccine. Some technologies would be more amenable to ramp up than others. I believe the CARES Act says that anybody who needs it, I know the wording is that treatment and testing are covered if you can get it. I mean, we can get treatment, but not everybody, the testing has been problematic. So hopefully this will also be considered treatment, and that people who need the vaccine will be able to get it.
I mean, the testing's tricky right now, but I'm skewed because I'm in the ER, but I can get all my patients tested. So if you're sick and you're having symptoms, or you're a healthcare worker, or I think now Lily's lab extends to anybody who lives in a house with healthcare workers or essential workers, like, we can test you. It's not that we can't test. I mean, we don't know the sensitivity and specificity that well of the test that we're doing, but we are testing people. And I know in my experience, in the last week working, I've had a lot more patients who are coming in who have known positive tests because they were tested in the outside world. And in reality, we're seeing patients that are getting sick 8, 9, 10 days into their illness. So it's actually been kind of helpful because they come in and they know they're COVID positive, and it makes it actually kind of easier for us because we know what we're treating.
But we're entering allergy season for many people. Some people have it in the spring. I get it in the fall. Many cases, it'll be allergy. But at what point should a person be concerned enough about pulmonary issues that he or she should call a doctor or show up at an emergency room?
I would say if you're having any sort of symptoms and you don't normally have allergies, for sure, call your doctor, at least start there. I would say if you have a fever, I think we're seeing an overwhelming amount of cases still having fevers. So if you have a fever and you're having respiratory symptoms, by all means, reach out to your doctor. Like I said, a lot of doctors are using telehealth platforms, but if you're truly short of breath or you feel like you can't breathe, then come to the ER. Like there should be nothing stopping you there. It should be the same as before this. If you don't feel good, if you're short of breath, if you're feeling, we're seeing a lot of diarrhea with COVID. So if you're feeling dehydrated, feel like you're going to pass out, like come see us. We will be more than happy to take care of you.
Question from Cantor Melissa Cohen. When do you feel people will feel completely comfortable to return to, quote, normal? Yes, at some point the governor will release a gradual plan, but what do you feel will be an accepted sign for people to feel they are no longer in danger? That's an important question for us as a congregation as we begin to plan for religious observances, both personal and congregational. How do we assess, despite state prescriptions, what is appropriate for the individual and the community?
I don't know. I think everybody's going to have a different inflection point, right? I think people who are at higher risk will probably be slower to come out, and I think that's reasonable. And I don't know, Rabbi, before everything shut down, there was guidance on trying to have the middle seat empty, right, so to speak, but not having people right next to each other, but having rows or seats empty. Maybe not. I don't know what the implications are going to be for high holy day services, right? When it's busy, the congregation, the synagogue is full. I wish I knew.
Yep. That's we all share in not being prophets here yet. We're a non-for-profit, but we're not prophets. Other questions? Thoughts on people who will choose not to vaccinate. Do you think this will now exist always in some way, the way that TB or polio has returned, though in small amounts, because some people choose not to vaccinate? Will people be hesitant to vaccinate because of the newness of the vaccine? And some people have resistance to vaccination in any case.
So I thought this might end the anti-vaxxer movement, but I think already there are people saying they would not want an anti-COVID vaccine. I really don't know what to say about that.
I mean, I saw a meme the other day that I thought was great, that instead of believing all the experts and scientists, people are going to start believing that person who got all C's in high school science. I mean, people are going to believe what they're going to believe. I don't think that's going to change.
Yep.
But I do think there's, in healthcare, right? We require flu vaccines. And that is a requirement if you're going to work at any of our hospitals in the city. I think it really raises interesting questions. If there is a safe, effective vaccine available, is that going to be mandatory for some of these occupations?
Mm-hmm. And the issue is, what are those occupations, right? Here's a question from Lori Pilot. I've heard of people who had to be tested multiple times before they were actually positive. Is that a reflection on poor sensitivity, inadequate viral load, or some other factor?
Probably all three. So if you test too early, you might miss it. There just may not be enough virus. It may be technique. Most of the tests use a nasopharyngeal swab, so you have to get it really far back, and it's not comfortable. Not to say you shouldn't get the test done, but there is a certain technique there. And also, like I said, we don't really know the various tests out there were quickly developed and approved, so there may be sensitivity issues with the test.
Is there anything that you would like to say to one another in the performance of your respective areas of the profession? An interesting conversation between the epidemiologist and the ER practitioner.
I think we have different perspectives. So Dr. Harper has been actually taking care of the patients. I will hopefully be able to do that in June. That's when I'm next supposed to. I've been the behind the scenes. What are we doing on the hospital level to get treatments to people and keep people safe? So I think we both have different stresses. But it's certainly, people ask me if I ever thought I would be dealing with a pandemic, and I guess I really didn't, although part of me knew it was possible. I'm just amazed at how professional our people are at Eskenazi, and I'm sure at St. Vincent's, just coming into work every day and doing really hard work. It's been stressful for our physicians. You all probably know we've really restricted visitors. And that was a painful decision for us. We felt we really needed to do that so we could focus on taking care of patients. But the visitor restrictions have been distressing for all of us.
Well, this is a good opportunity to thank, through the two of you, all the people in the front lines and the medical and other service professions who are taking care of us during this difficult and at least for 100 years or so, unprecedented time. There is a question in the chat box about pregnancy. Is there a specific question, or is just a question, what can you tell pregnant women at this time?
So I would say still come in to give birth. I've heard that some women who normally would have given birth in a hospital are opting to give birth at home. I mean, if that would have been your choice anyway, that's fine. But I think, you know, the hospital, we are still like Dr. Harper was saying, we're still keeping people safe. I hesitate to say anything because this is such a new virus. You should certainly do your social distancing as anybody would. We're starting actually to do testing on all pregnant women coming in for labor at Eskenazi, and IU Health is doing that as well. I don't know if St. Vincent is doing that as well. So you will probably be tested when you come in. That's a precautionary measure. But that's, if you did test positive, we could take proactive action to make sure your baby was safe. But
yeah, so what we've done at St. Vincent's, at least on our side, is that we have a couple different hospitals. So women's is separate from the main hospital. So anybody who's pregnant, and I've seen a few pregnant patients in the last week, who have symptoms of COVID and are getting admitted, they're getting admitted to the main St. Vincent's and not to women. So they're trying their best to keep women's as a clean site. And also, as Dr. P can probably tell you, the St. Vincent's Heart Center also doesn't have any COVID patients. Anyone who comes in there with symptoms is getting transferred over to 86th Street. So we are separating them out a little bit. I think if you are pregnant and you have symptoms, you still need to be seen and treated. We're having a lower threshold for admitting patients who are pregnant, but we haven't seen, I mean, I was pregnant during H1N1, so this like brings me back to all that, but we haven't seen any real changes in pregnant people getting sicker from COVID than anybody else.
In New York City, most of the pregnant women who had it had no symptoms.
Yeah.
So we are testing, even if you don't have symptoms. Well, you could refuse a test, but we are recommending testing even if you don't have symptoms, not for the whole pregnancy, but again, when you come in and you're about to give birth, just because we could do things proactively to protect your baby. We're not separate. We don't have a separate hospital, but every single room at Eskenazi is private. So you're always going to be in your own room.
Well, we are coming to the end of our conversation. Unless there is another question, I'm seeing a lot of expressions of gratitude for our panelists this evening and for all the doctors who are out there, nurses, caregivers, and all who are in the front lines helping us to deal with this very difficult and unprecedented situation. I'd like to thank Amy and Jamie for joining us this evening, and all of you for participating in what I think has been not only a very informative, educational conversation, but a very sensitive and caring approach to an issue that touches us all. There is one more question.
Can I make a comment, Rabbi, first? I can
Sure.
see some of the comments coming across the bottom, and I can see some people talking about social distancing and when they would be
Ready for
comfortable with it. And I would just say that even if the governor opens things up and says people can go out, that doesn't mean that you shouldn't judge your personal situation, your health situation. You don't have to go out. It's okay to maintain, social distancing, wearing masks in public, even once they do open up businesses and stuff. You got to be smart about you and take care of you. So I totally agree with whoever wrote the chat that they wouldn't be comfortable. Like, do what's right for you.
Right. It's not a universal directive, and certainly not a mandate. Right. There's a question from Alan Hamburger about the shingles vaccine, which experienced an immediate backlog. Have lessons been learned from that to reduce the probability of a new vaccine? On a new vaccine.
So I think with the shingles vaccine, the manufacturer did not anticipate how much demand there would be. I think they thought, I don't know, but I think they were caught off guard. And again, I think whether or not that would happen with a COVAX vaccine would really depend on how it was made. Like there's certain techniques and technologies that would be easier to ramp up than others. So every year we make lots and lots and lots of influenza vaccine. So I don't know if that tells us anything.
Well, once again, thank you, doctors, Dr. Jamie, Dr. Amy, our dear friends and trusted colleagues, for all that you do for the community and for taking time to participate with us in this conversation this evening. All of you for joining us. A lot of programs next week, continuing both educationally and religiously in the life of the synagogue. Please pay attention to all those releases that Jackie Goldstein and Sherry Levine put out, letting us connect with the congregation in so many different ways. Thank you all for joining us. Thank you, Dr. Kressel, Dr. Harper, and all who have come to participate in this evening's dialogue.
Thank you for inviting us.
Thank you. And stay healthy and stay home as much as you can, and take in some fresh air whenever you can as well. Thanks.
Thanks.
Good night.
Laila Tov. Good evening.
Good night.
Good night.